I'd like to, begin by, hey, good morning, by saying a good morning to all of you. Thank you for joining this session. I know it clashes a bit with the plenary as well. So if anyone is here, it is because they are truly interested in this topic on men and HIV, which, like we see, I can see a few nods. It's a really important topic. My name is Wole Ameyan. I am the WHO lead on men and HIV. And today I will be taking you through what I hope will be a conversation. So you will see that rather than slides or presentations, we will likely be doing away with slides, but rather just have people, subject matter experts, come on stage and speak to the challenges, and we know there are quite a few of them. The challenges of reaching men in different countries and improving outcomes. There are certainly strategies that we know now. The WHO framework, the WHO and UNAIDS framework on men and HIV was launched last year. So we can't say we don't know what to do. So we know that the topic is important. We know what to do, but I think we need a bit more iteration and discussion about this topic. So we'll have an evolving conversation involving different people in the audience, and then try to build a conversation around recent research, strategies, challenges, but also hopefully we can talk about some future directions and where we need to go. So just to say that in the course of this, I'm struggling with what to call it. Is it a meeting, or in the course of this conversation, we will be having 3 or perhaps 4 checkpoints with people in the audience. But also, I understand there are quite a few people online. Let me welcome you as well. You will have an opportunity to chime in, offer your insights, your experiences, and I'm sure there's quite a few of them, so that we can have hopefully a rich conversation. On the next slide, I will start with, I know I said no slides, but just a few slides. There will be perhaps 3 or 4 slides. I think just to set the tone, a tone that I'm sure some of you know about the gaps that we have seen. The recent UNH report shows certainly gaps along the 3 95s, and you can see here, 83, 72, and 67 for people who know their status are on treatment and virus supplies for men compared to women. So there's, in some parts, close to a 10 percentage point difference between men and women. But always I say it's not really about what the difference is. It's more about, does it make sense to close this gap and try to end AIDS in 2030 by a focus on men? Now, that's the conversation I think we need to have, and hopefully we will be able to do that today. On the next slide, you will see the regional differences. So what you see with the numbers are the percentage differences. So you can see in Eastern Europe and Central Asia, just in the middle there is a 20% difference between men and women. But the story is the same across all regions, except just a few in Latin America and in the Middle East. But from the Asia Pacific to Eastern Southern Africa to Western Central Africa, there are huge gaps between men and women, and there's a lot of struggle in trying to shore up treatment access, but also suppressing the virus in men. Next slide. The next slide, I believe, is on the absolute numbers. So sometimes, we speak about percentages, but this is just to show that we're talking about hundreds of thousands of men, across the globe who are missing from care. many of them undiagnosed and without any, of course, if you're not diagnosed, it becomes really difficult, of course, to get on treatment, to be virally suppressed, and to prevent HIV transmission. Next slide. And so came this work from the Pangea Institute, and I found this really compelling. I did mention something about it at the ICASA conference in Zimbabwe, and they did some really compelling work, which showed that had we focused, done a bit more on focusing on men and reducing viral suppression in men, we could have reduced HIV infections in women by a staggering 50%. I think that is a cause to ponder. I mean, if we're not doing anything, certainly when you see work like this, we should be able to sit back and think and look at the direction that we're taking globally in ending AIDS and seeing how we can begin to focus on a holistic population, not just women, but also men as well. Next slide. Yes, so this is probably my last slide before switching the mode of the discussion, and it's about and I encourage you as well as you listen to the speakers to think about how we think about the path to ending AIDS. I think as a global community, we need to begin to question some of the answers we have and see if we really are doing the right things in a short while. I mean, 2030 is I mean, we're looking at it right now, and we have to be able to see if perhaps we need to course correct in reaching the right populations. The middle there talks about just go back switching off the tap, and it might sound cliched, but I think while it is so important to have a focus on preventing new infections in adolescent girls and young women, we know that's really key. Up to 4 in 5 new infections in East and Southern Africa, for instance, amongst adolescent girls and young women. So that's a really important focus. However, as we try to mop up our new infections, we need to think about, switching up the tap of new infections, the sources of infections. And I think that's where hopefully the men conversation comes in. On the next slide, I will be going back to that slide again, which, like I mentioned, was a study done by the Pangea Institute, which, again, for the sake of emphasis, shows that had we focused and tried to do more with men, we could have reduced new infections in women by up to half. Now, I didn't do this research, but I have someone here who is part of the network, of the Pangea network, who did this. And he's going to be my first speaker, or my first conversant who will try to speak to this. And he is Dr. Sikulele Moyo, who is a member of the Pangea Executive Committee. And we have him here. If you can come with me. Yeah, so my voice is a bit cracky. It's been a good conference, I have to say. But let me say thank you so much for hitting our call. It was actually a bit of a last minute coming in. So it's really great that you've been able to come and to discuss particularly this work, which for me, the first time that I saw this research was a friend sent it to me who works in one of the research institutes and showed your compelling results as well. I'm very interested first in the why you decided to do this work, because like I said, over time there's been from research to even implementation, there's been a lack of, I'm not sure if I can call it interest, in focusing on men, but you did this work. So was it happenstance or was there an intentional understanding of what you wanted to do.
Thanks, Wole, and thanks everyone for coming to this discussion. I hope we make it a discussion, quite an interesting topic and passionate and close to our hearts. From the Pangea Network, which stands for Phylogenetics or Networks in Generalized Epidemics in Eastern in Africa. So this network involves researchers in Eastern Southern Africa. We've co-host longitudinal studies that we've been following for a long time. And we were interested in understanding what are the drivers of transmission. And we know a lot about recipients. And we wanted to know what are the characteristics of the sources. And we combined an innovative approach of using both viral genomics and epidemiology to enrich our understanding of, okay, we see the recipients, we characterize the recipients in many ways, but who are the sources? And we did this work in Rakai in Uganda, very large studies in communities being followed over time, in Zambia, in South Africa, in Pop Art, and in Botswana, in Yatsie, the Botswana Combination Prevention Study. By innovating tools to understand, characterize the pairs of transmission, we're able to quantify, at least to put some quantification of the proportions of transmissions that are coming from a male source or from a female source. The slide you showed was really staggering for us because we observed that infections from a male source were twice as much as infections from a female source. And this was consistent from Rakai, it was consistent in Zambia that we observed, and also in Yatsie that we observed. In Pop Art, for example, we saw that 3 out of 5 of the transmission pairs had the male source. And in Yatsie as well, out of quantifying about 82 transmission pairs that we observed, 43 of them were actually from a male source. And when we looked over time, because these studies have been conducted, some of them for more than 2 decades, we saw that the gender disparity in terms of contribution towards onward transmission kept on increasing over time, and highlighting probably, for example, in Rakai, we see that 43% of the transmissions were actually coming from a particular age group, 25 to 40, which was very important and new information from us, adding to what we've already observed before.
Absolutely. And I'm so interested as well in that 25 to 40 age group, because it sort of pinpoints, for policy where we can focus, the age group that we should focus. In terms of the findings, the one I showed just on the slide that showed if we had focused on that age group, we could have halved infections by 50% in women. Could you take me through that? What was the process of going from the research and interpreting that research to reach that conclusion?
That was informed by many things. We modeled many counterfactual scenarios to really look at from the data that we are seeing, which from the modeled estimates, we could see that because of disproportionate viremia that is occurring in those age groups, most of the infections were coming from there. And also we modeled and see, okay, if in 2018 or 2019, had we targeted those age groups and reduced the infection rates and calculated what was the likelihood of transmission events that would have seen, we saw that it would have reduced more than 50% in females, which is important, that interventions that we are making in males have an important impact on females. So which means that really focusing on men has really benefit, not only for men for their own health and viral suppression in general, but also for females.
Compelling. Which again brings me to the cascade of HIV. So it's not just the end of the cascade, which is viral suppression, but we have to be able to come as well to the beginning, and that's prevention. I don't think we speak you know a lot about that. So while it is important, you know, certainly from your study to have that focus on treatment and suppressing the virus, it also speaks to the need to prevent as well. So having that connection between prevention, treatment, and then ultimately virus suppression, is there anything you can say about that?
I think is very important to make sure that individuals who are viremic in the community, who are the likely drivers of or transmission, if we can target innovative ways of finding these individuals. In all our studies, one of the things it was challenging to find men. So we had to innovate in different ways in our communities. We work with communities. We work with many people who are really trying to understand the dynamics within the community and inform us strategies in which we can reach men. And that was very, 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 very informative in that at least we can adapt our strategies to bring men in. And our next steps now is just to make sure that we access as many men as possible using varied methods of sampling, because house to house alone, you miss a certain number of men, and venue-based testing becomes very important. Looking at strategic areas where you can get men becomes also very, very important.
Fantastic. Thank you so much. And I think, you know, for me, it's congratulations on your work. But we're also looking forward. I'm sure you have other things in the pipeline that are coming. Hopefully we have some time to talk about that. You know, you spoke about the link between virus suppression, but also linking it to prevention. I mean, on prevention, one of the bastions of HIV prevention for men, I'm sure you know, you mentioned the RACI, is VMMC, so voluntary medical male circumcision, which over time has been really impactful in reaching men. Over 35 million men reached since the recommendations were made in 2007. Sometimes I feel, you know, as well, you might have a reflection on that we haven't made as much use of VMMC as we should in the men space. There are lots of lessons to learn from that, I think I'll bring in my second speaker to speak on that VMMC particularly. So we have Dr. Carlos Toledo, who we know he is a round of applause, please.
Where do you want me to say?
You can sit here.
Okay.
Yes. So Carlos, I know Carlos when I joined WHO in 2018. I was a bit lost, I have to say. I wasn't really quite sure how to navigate the space that I was in, because it was a big job, I have to say. But who had been working on VMMC, I read a lot of his papers. I had chats with him to you know, help as well. So thank you for joining. Delighted you're able to be here. Perhaps to have you speak to what Sekulele mentioned. What do you make of his the work that he mentioned?
Yeah, no, first of all, thank you, Wole, for not only inviting me, but really for having this session. I think this not only is an important session, but it really is the only opportunity we've had to talk about circumcision at this conference in an oral. So, and it's been a long time, I think, since this meeting has actually had a session on circumcision. So thank you to WHO and the other players who have really emphasized the important role of circumcision. The Pangea work has been, you know, fantastic, and really, it's something that I think many of us intuitively knew, right? And because we followed that work, and you know, the studies in RACI and other places sort of had pointed us in that direction and have been saying that for a while. But this really confirmed it in a way that I think that we didn't previously have, especially because one of the things that I've noticed about circumcision is we often focus so much on like the benefits to men, but as you said, it's not only the benefits to men in HIV, the benefits to men in a array of other conditions. There's also the benefits to women, and a completely other side that we don't even talk about at all is like the benefits to the system. The fact that we have trained thousands of nurses in a surgical procedure is a systems change, right? And when the circumcision program had to be halted in 2020 because of COVID, many of those resources that existed within the circumcision program were repurposed immediately, because those were the people who were trained. They were trained on IPC, they were trained on, you know, important procedures, and we don't often think about the impact that the circumcision program has had on the system, as well as the men, which are obviously important and our primary focus, other diseases like STIs, and women. So I think the work from Henji, I think, is just fantastic, and I'm so glad that they did it.
I would agree with that, and I think you've mentioned as well the need to use what we have and the lessons on VMMC and seeing how that benefits, you know, more the system as well. Perhaps that hasn't been done as well as we could. So you know better than most the fact that VMMC, you know, even from the original recommendation, was to be provided not as a sole intervention, but, you know, as a combination. It is VMMC with HIV testing, with STIs management, and all the other interventions. So perhaps I would ask you about how you see the trajectory of VMMC. How have you seen it over time? How it has evolved? You know, like we said, it's such a great intervention for men. But how do you see the evolution of VMMC?
No, thanks, Wally. Let me just also add, it's not even just that package of original services. Many countries have really added additional services to that package, right? Vaccinations, screening for hypertension, and every country has to think about. You know, now we talk about this idea of integrations. You know, it's a new concept, which, in fact, at least in many of the circumcision programs, have already been integrating some level of services. Evolution of the VMMC program. I mean, it's interesting preparing for this conversation because I feel like the historian in the room, even though many people in the room that I recognize were there at the beginning, maybe not as closely, some as closely, but you know, there's few of us that are left from those from the early 2009, 2010 that are still working in this space, and what an evolution to the. In some ways, obviously, I've seen the numbers over time, but the fact that we are at 38 million, it's like, or nearly 38 million, it's insane. I mean, I remember our first target, which I think it was like 4 million, and we never, and I'm saying, Anjali, like, I don't think we ever thought we were going to reach that. I mean, like, it was like, no way. I mean, yeah, we put resources, but like, there is no way we're going to reach this target. And we did, right? And then we upped the target and we did it again and just continued in this trajectory to where we were doing 4 million, 2017, 18, 19, around 4 million. So what I find interesting thinking back on like that momentum that we had in 2009 and there was like a real global consensus on what needed to be done, right? There were targets that we all globally had agreed to. There was a vision for like what program implementation should do. There were quality standards, right? Which is one of the things that I think was incredibly important from WHO at the very beginning, was the establishment of quality standards. Because you can't do an intervention without having quality, right? And without making sure that the patient, the client, feels like that they're receiving a service that's of high quality. And I don't mean that. I mean, when we think of circumcision, obviously we think of the surgical procedure, but when we would do quality assessments, and when we still do quality assessments, that's the area that we find the least deficiencies. Like, people know how to do the procedure and people are trained very well and do the procedure. It's everything else around it, the counseling, the education, the supply chain system. All those things need to be of high quality and need to be held to a certain standard. And I do think that that is a lesson to be learned from VMMC that I'm not sure has been translated to other programs. So I would definitely say that that focus on quality is a lesson that for other programs, the kind of the consensus on the target, and we were all working towards this goal, which we know was based on estimates of impact, right? We knew that if we got this this far, we would have this kind of an effect. And you know, the truth is that bottom line, like the MMC continues to be the most cost-effective intervention that we have,
Right.
no matter how you look at it, and in many cases, cost saving.
Right.
So if there's anything that I would like emphasize going home, like even as we talk about epidemic control and we talk about all these other options, and yes, men have many more options now than they did in 2009 when we started the program. But as we talk about a choice agenda, this needs to be part of that choice. And we know that the circumcisions you're doing today will have an impact for that lifetime. It is the longest acting agent we have.
Fantastic. So that brings me a bit to some of the challenges as well.
Yeah.
So you've mentioned, I think it's for me, it's very insightful when you mentioned the global consensus that we had then compared to now. I mean, now we're even struggling with understanding whether we're scaling up or we're sustaining, or, you know, the all of those conversations that we're still having, that it doesn't feel like there is a unanimous understanding of where we should really be going. But of course, with understanding that countries will be different, right? It's contextual. What happens in one country will have to be, doesn't have to be similar to what happens in another. So my question is on some of the challenges on that. Why is an intervention that you, like you said, is, you know, very cost effective? It's largely, you know, it's safe. It's met the needs of over 35 million people, men. Why is it not as mainstreamed as we would?
Yeah, no, that's an excellent question, and I do think that that is the main challenge right now for this intervention, right? Like the long-term sustainability of it is a question. It's a question mark, and I actually remember, you know, this very question had been asked of the MMC group in terms of like, how long do we need to be doing this when men have many other choices? Unfortunately, you know, every modeling that we did, no matter how we looked at it, said you need to continue it as long as incidence looks like what it looks like in most countries, in most settings. We need to, in generalized epidemics, we need to continue to do it. So like the answer was the same. So, and I'm not sure, it doesn't mean that we need to be doing it in 2050. It doesn't even need that we need to be doing it in 2040. But in the immediate term, as we think about you know, reaching 2030, this is an intervention that we need to continue to accelerate, really, to reach these high levels. Because again, every circumcision we do today has a long-term impact. But I wanted to say, you know, it's not a sexy intervention. Like, it's never been a sexy intervention. You say circumcision, and people are just like, oh God, you know, here I mean, it just hasn't. It has been a hard sell, and for many reasons. You know, it is latent with cultural, religious. I mean, many. You can go down the line in terms of reasons. So it's always struggled that way. I think currently there's just a lot more choices, and people are really excited about those, and I think that's great. But you know, if you ask me, I think, and at least the data, if you're going to make informed decisions based on data, there's a role for it, especially to continue to accelerate it currently.
Fantastic. I would say, and correct me if I'm wrong, the successes that you mentioned have been driven by communities, you know, community, especially with the demand creation. how important is that role for communities? And I'll be going into a conversation about communities in a minute, but I wanted you to just paint a picture for us on the role of communities in driving the success of VMX.
Yeah, no, excellent question. And I would say we would never have circumcised 38 million men if there wasn't community involvement. And like it was just so embedded with what needed to be done, because you're talking about very strongly held cultural beliefs around circumcision. And in order to in order to change that, or to inform that, or for people to make informed decisions about it, you had to engage communities. And from early on, I mean, it was just embedded within the things you had to do, right? You had to buy commodities, you also had to engage community, right? Like it was just, that was part of it. You had to talk to traditional leaders, community leaders. And we knew that, you know, mobilization like was better if the person got to speak to somebody who either had gone through the procedure or you know, or knew, was close enough to it to be able to talk about like the quality of it. So I would say, I always say, like, it is part of that package of programming. And we would have never been able to reach the targets that we have and the numbers that we had if there wasn't that level of engagement with communities. I like at the most rudimentary as well as the highest level.
Fantastic. Thanks for that. And Sekulele, if I can bring you in on, again, going back to that work that you did, there were a few community implications in terms of transmission within cohorts. Was that something that came out of that work?
Yeah, in terms of, we learned lessons on how to engage communities, right, how to bring communities to be at the center. And the nature of our work definitely needed a conversation with the communities. We involved them in our work in understanding the ethics of using viral genomics. And we learned how to communicate the findings, how to make sure they are meaningful, what do they mean and what do they not mean. And now in our next phases of the kind of work that we do, the community is at the center of really trying. They want to understand what is happening with all the interventions, where are the infections coming from. So that drives us. And when bringing these tools and shaping these tools and also introducing newer guidelines that have come in terms of how to interpret and use this data, we are going back to the communities. And some of the qualitative work has informed us on how to reach men, right, and how to engage men, and what strategies and what facilities to use and what times of the week are convenient, and how to reach men, and mixing all these, we think that are going to be useful in bringing men to testing and to care.
Fantastic. I am delighted to say that we have in our midst Nelson Otwoma, who is the Executive Director of the National Empowerment of the National Network of People Living with HIV in Kenya. Nelson has been a stalwart, I have to say. He's part of, you know, all of our men groups. He's present. He's driving this agenda, particularly in communities. And it is a pleasure, Nelson, if you can come up and join us. Sorry, if, we're not all. I think I'm leaning this way too much. Okay, thank you so much, Nelson. I know it's been a busy conference for you. You're in hot demand, you know, with sessions and, you know, trying to see you speak in different engagements. I would like you to just reflect a bit, particularly on the community conversations that we're having, the key role of communities. You know, we speak about tokenism. Sometimes community engagement becomes a buzzword that people use, you know, for different reasons. But I think it is such an important element that we need to make sure we're doing it right. And my first question to you is, you know, to perhaps speak to us about how key that community engagement is, and how real it should be as well.
Thank you very much, and thanks you for having me in this dialogue. Of course, before I go into your question, I just wanted to reflect on how it is important to make sure that men also benefit from the science of HIV prevention and even treatment and care. When we started, sometimes I think what baffles us is that the first batch of people who are talking about HIV in 1980s going to 1990s were men. And then somewhere along the line, they got lost. Now we are saying they're being left behind. And I think healthcare workers are trying, ministries of health are trying, but they are getting like disparate attempts. Like you see a pregnant woman, then you tell them, go and bring your sexual partner. So they're using women as a bait to reach the men who probably are not coming in. And so sometimes it works, sometimes it does not work well. But we also know that where we are, we have the tools, we have the knowledge, we have the technology, and that it is people need just to test themselves and then adhere to treatment. They're virtually suppressed and you're living good quality life. But this is not happening very much for men and boys. They tend to test late, and when they test late, even immediate enrollment for treatment and adherence becomes a challenge. So I wanted to reflect into your question and agree with the first two speakers that it is important to reach out to communities, in this case, men vulnerable to HIV infection and men living with HIV, to uptake of these services. And the way it is going to work is if they are empowered, they have the knowledge, and they are respected so that their engagement is meaningful from the design. The discussion need to come in before interventions are rolled out to ask them, where will we get men? Where do you prefer to go? And I think what we've said in the past is that men exist in their diversity. So there's no one way or one strategy that really will capture all the men. Some men will respond because they want to protect their families. But I think the most important thing is that approach men as human beings, as men, not because you want their wives, not because you want their children, but as men, because some may not even have wives, some may not even have children. But what is important is that we approach men as human beings who deserve and who are deserving of care and treatment. Thank you. Thank you for that.
So I'm happy you mentioned that, Nelson. I think one of the biggest issues that we've had in the men's space is the narrative and the perception as well, some of which is generalized. So like you said, it's about putting men in a box to say, okay, this is how a man is, or this is how a man has to behave. This is how men act. And I think it sets the conversation backwards, right? And I'm so delighted you've mentioned that, as I pivot as well into specific examples. And I'm going to be, coming to both speakers to my right as well. We need, certainly, sometimes we call it good practices or best practice examples. Are there those you can share with us, particularly when it comes to community engagement and male engagement?
Yeah, I think there are a number of those who do interventions, and there are strategies that work for men. And as I've said, there is no one strategy that fits all men. But what is important really is to approach HIV in the larger confines of health. When we approach it in the larger confines of health, then it would basically also mean that we are minimizing stigma and tackling stigma at the same time. So it is important that men actually, as they grow into 40, going into 50, we also look into other conditions and other social issues. So it is not just purely clinical aspects of HIV. And I think the issue is, of course, our burden mostly in sub-Saharan Africa is HIV is feminized. So basically it is good for healthcare workers to think that I need to see a woman, I need to see a child. But we also need to get out of the facility. We need to get to social places where men are. We need to, where do they watch the football? And what is trending? And where, how can we have the conversation on economic issues? How can we talk about non-health, but the issues that are important even at workplace? And where will boys get employment after their education? So such opportunities that can bring men together, then we bring health information, including treatment information. Now we are talking about HIV, which with the treatment is a long-term chronic medical condition. So I think we need to go less on the clinical aspects and look more on the non-clinical, like the social issues, because much the same way with the men with hypertension, they will go buy their medication and take it, but focus on their work and other things. But for the HIV, you need that conversation. You still insist that men should be coming to your facilities almost every month, and in a type of environment where the younger people they meet, they tend to be female, and the thinking tend to be feminized, and the questions tend to be, what about, are you married? Do you have children? So I think if we get out of that and get to community where we can talk about non-health issues and then use that to make sure that men are enrolled into care for those who are tested, who are not tested, are even tested, then that would work much better, so that men start to believe that those who work in the health also care for other components. They care for social issues, they care for cultural issues, they care for economic issues, and even workplace. Yeah, that would work.
Oh, fantastic. I think the two issues on changing the narrative, but also providing integrated services as well, beyond just one, I think are key issues. Carlos, if I can ask you about, and I'm sure community engagement is going to be one of the lessons we can learn as well, but are there other lessons that we can learn from VMMC that we can sort of translate and pivot into this men work?
Yeah, no, I mean, I completely agree about the selling of men care about other things besides HIV, and we need to be able to speak to that. And I think be able to differentiate some men, the HIV message resonates with, but not all men, right? And being able to differentiate between what message works for this men versus these men, I think is really key. I actually did want to bring up something which I don't think that we have expanded on, which is really how powerful U equals U could be as an intervention for this population. Because as we talk about viral suppression, like the idea that if you are undetectable, you will be untransmittable, like that is such a powerful message that I don't believe they have received before. And I think some of the work that I know some in the room have done in South Africa, I have shown that really is a really powerful message. And I think I wish that we have a lot more conversation around that as a way to address this issue.
Thank you so much, Carlos. Yes, there are people in the room, I'm sure, who have experiences to share. So just give me a minute. Let me, try to just get a few things covered as well. In the next probably 5 minutes, I will be opening it up to the audience to chime in with your experiences and suggestions. If you have any questions for any of the panelists as well, please feel free to hold those. Colleagues on the line, I know there are quite a good number as well. Thank you so much for joining. If you have questions as well or thoughts, please raise your hand and I will be more than happy to call on you. So I come back to you, Robert, on communities and structures. I think one of the most important structures in communities is our traditional institutions and our traditional structures. Perhaps the question is, what sort of engagement do you, as a leader in the community, have with the sort of traditional structures and the traditional leaders, and how vital do you think they are in this messaging?
Yeah, as I said, we are not going to have one approach, and even in terms of structures, we will look at traditional structures, but also evolving structures. I know in communities where we come from, men have clubs or also their leadership structures or clan structures. Some of even are faith sector structures. Actually very important at reaching at men with information, even the faith sector structures. and even the cultural indigenous institutions are really very important. They have really been very important in terms of preventing HIV and sharing that information. But we also see that the moment people test HIV positive, they try to isolate themselves from structures and form other structures. That is how support groups come in. That is how men's clubs, positive men's clubs come in, because then they are not comfortable sharing their status, talking about these structures. And those who continue to be in those structures, if they're positive, tend to be in denial and present with health outcomes. So at a higher level, you need the chiefs, you need the religious leaders to send messages, which is still welcome. But for people who actually have crossed the line and are HIV positive, you need to go deeper and look at specific men's clubs and networks of people who are positive to sustain them into care. But all structures do matter in terms of the HIV response, including family structures that sometimes people put together to cope with the challenges that come in. It is also that those structures that also help men cope with medical bills in case when they delay treatment and opportunistic infections come in. And right now we are talking about advanced HIV disease. Again, they are dependent on those structures, including employment places for those who are on employment. It is really important to access them through those structures. But I also want to emphasize the importance of what the previous speakers talked about, U equals U. And because this is what is now transforming HIV, like I said, from life-threatening illness to a long-term chronic medical condition, and there where you have quality of your life. Before we started talking here, there was a presentation, and of course, the science tell us that there are more infections coming from men. Depending on how that is communicated, it ends up being saying that probably men are mobile vectors of HIV transmission. So what is important is that men make sure that they mute the virus in their body through treatment. This need to explain properly so that they feel accepted. They don't feel like they are the people who are causing this havoc and this epidemic. And that is where U equals U comes in. Thank you.
I couldn't agree more. Before I pivot to the audience, I think I would like to bring in that traditional institution perspective into this panel. And I am delighted to have Mr. Robert Sewanga, who is the Minister of Youth, Sports and Culture in the Buganda Kingdom in Uganda. What a pleasure to have you. I was just taking permission from him to call him Mr. Robert, which I think is easier for me. But thank you so much for coming. You've heard from the speakers the role of communities, how important it is to to engage communities. You are a community leader. You know our structures in the communities and the role of traditional institutions, and how powerful they are as well, in supporting this cause. Perhaps you can give us that insight into how our traditional institutions, our traditional leaders can more or less lead this, and make this this Men and HIV work strong.
Thank you. And I want to thank my colleagues here that you've done so well in terms of science. You've done so well in all this work you're putting across. I congratulate you in your hard work. And us there, you're working for, particularly the Buganda Kingdom, we've seen your science work in intervention. Robert Sewanga is my name. I'm Minister of Youth, Sports and Arts in Buganda Kingdom. Buganda Kingdom is one of the biggest kingdoms in Uganda. Amongst them, that is where we hail, and our stream leader is the Kabaka of Buganda. Slide number 2, please. is the king of Buganda, and he's the one now the goodwill ambassador. That is the gentleman you see out there. He's now a goodwill ambassador, and most of the work, because we shall not have a lot of time, you'll be seeing them in that YouTube. You when you go to that YouTube, you'll see more of how we are doing this work. Now, in terms of traditional leaders, we are going to look at an aspect of culture, and culture is what we follow. These are shared values. These are our shared norms. It doesn't bring any type of education into it. You grow up like that. You believe like that, and changing it sometimes becomes very difficult unless you have to bring different aspects into play. And because of culture, this is what we consider acceptable. This is what we consider appropriate. This is what we consider desirable. So if you're bringing any type of intervention, we have to consider it acceptable, appropriate, and desirable. So however good it is, if it doesn't pass that test, then it becomes very difficult to change somewhat out there. And this influences the way we learn, the way we live, and the way we behave. So you find a man very rude, you find a man walking high, however broke he is the man in the home, you don't have anything to say about it. That is how he has been brought up, that is his culture. And therefore, this is also brings in the shared responsibility and also guides thoughts and also guides the way the community learns. Slide number 3, please.
So if I can just come in just briefly, I think what you've mentioned in terms of the some of the results and the success that you have is really key. Could I just have you speak to the successes that you've had, just if you can summarize what particular successes have you had in engaging traditional leaders and trying to support, like you said, the work that Robert is doing, Carlos and Nelson as well, to bring everyone together. Because more than anything, you are the leader in communities that brings everyone together. So are there examples of that?
Success as a traditional leader in this type of interventions, but there are many ways we've done it, but I'm going to just mention just four, summarize. Now, what we've done through His Majesty the Kabaka, it is simply to have HIV, and then we accept the monster as a challenge. So the whole community is alerted that HIV is a monster and HIV is a challenge. So now by accepting, slide number 3, please. By accepting, we do accept that HIV is with us, first and foremost. And it is a monster killing our brothers, killing our sisters, affecting families and all that. And in all our cultural aspects, we bring it in. And what it does is we try to embed culture. Slide number 3, please. Next slide. Yeah. So we have that. And next slide. We have, you can play that. We're trying to accept that is a monster. And you see that when people come together, most activities are done that way. In all our interventions, we do that. Whoever comes together, everything that we can. Old, young, we all bring them together, tell them that this is it. Next slide, please. Now here we embed interventions in all our cultural activities. If you're going to marry, it is key that you test. That don't cause a problem. If we are happy in a day, we make sure I tell you 8 skills. If we're at a football game, we have 8 messages because we have so many competitions in Buganda. We have cycling, and our themes are AIDS intervention messages. If you're a man and circumcised, you're good to go. And it's printed on placards, it's printed everywhere. So we accept it as a way of living, we accept it as a way of life, and we accept it as a normal aspect. And when you're looking for men, men are our leaders in the homes. Men are the ones who lead change. So we do that, and all our cultural norms tend to do that kind of work.
Yes.
Yeah.
Thank you so much. I think these are really great insights. Can I ask you about culture and how it evolves? I think what you mentioned, especially from the video, is it just brought this up to me as well. How are we? Culture evolves, and it's not static as well. So I think we have a role as traditional leaders and institutions to sort of continue to evolve as times go by. So my question before I pivot to the audience would be, what does that look like in communities and traditional institutions, and how are they evolving with culture, if you see what I mean?
Yeah, thank you. I think that is very critical when it comes to culture. I want to let the audience know that culture is born, culture grows, and culture dies. For example, circumcision is not part of our culture, but to bring it in as an intervention aspect, you have to let it be born, okay? Involve traditional leaders, involve everyone. Like in Buganda, we have a structure of leadership where the Kabaka has with the ministers, he has community leaders, and you find that the total number of leaders just under the traditional structure can go up to 120,000 people. And these are men leading change in their communities. So if we accept that a new intervention from science is good for the community, then we have to take it to the cultures and let it be born, and let us give it time to grow. Then when it grows, it becomes acceptable, it becomes desirable. At the end of the day, an intervention becomes the way of life, which might lead change, which might lead so many aspects. So that is key. So don't just come and say this is a good science, and you take it to a community and you think they're going to adopt it. They'll just run away from it. So I want us to have the patience to have it born, to have it grow. And when it matures, hopefully by 2030, you won't have AIDS around that. And we expect by that time, if you engage the traditional leaders, you'll have a very good success. Yes.
That's an answer that I certainly like. It takes time. Culture evolves, and I'm happy with that analogy about connecting culture with evidence as well. I think it's something that is something we can take away. So I'm going to open it up now. I can see a few hands already, but I want us to have a succinct conversation. So if you can keep your submissions short, that would be fantastic. Those on the line as well, if you have any questions, please, or submissions, please, you can raise your hand. I've seen a few questions online, which I'll read out, but we have an opportunity here to offer brief comments, please.
Thank you very much for excellent conversations. My first question is directed to the Honorable Minister. You indicated that one of the interventions is to ask those who want to marry. The first thing is for them to be tested. Now, what happens if somebody between the two is positive and the other one is negative? Or if both of them are positive. So what is the other intervention? Then on VMMC, yes, as the world, I think we've circumcised 38 million, which is good for the world in terms of HIV prevention. But however, in some settings, it's not that glorious. I am from Botswana. Circumcision were at about 48%. We've been trying to target 90%, and we seem to be failing to get to that level. And we've realized that over the years, our strategy was VMMC specific, but looking at other HIV prevention models, combination prevention, which was good, in line with the global recommendation. But we forgot that there are other issues which affect men, like non-communicable diseases. And we are now trying to move towards that, where we develop a strategy which we call the male needs strategy, so that VMMC is not seen as a standalone strategy, but it's part of the broader needs of men. Thank you.
Thank you so much. That is a great submission. You have the panel will have some time to speak as well, please.
Yes, thank you. I applaud the focus on men and addressing HIV. I really think men are kind of the last frontier in HIV prevention. But two things I didn't hear mentioned here. There was a full-day pre-conference discussion on sexually transmitted infections, other sexually transmitted infections besides HIV. And I think your models need to think about how one addresses that in men. I've been in STI control for a long time, and clinics are the treatment recourse of last resort for men for STIs. And so how do the models that you're building address STIs and partner treatment as part of STI control? And the second issue is I didn't hear condoms mentioned once in this entire discussion. I know condoms are an old technology and people think that they're there, but current data suggests that condom use is going down, supplies are going down. Those programs need to be paid attention to and nurtured to ensure that this basic prevention tool is also part of our armamentarium.
Fantastic, great comments, thank you. So I'm going to take perhaps a couple more.
Thank you very much for great presentations. I'm Sheila Tlo, the chair of the Global HIV Prevention Coalition. Minister Sarawal, it's great to see you. I know they cut you short, but I really am hoping that you'll be able to say something about the Kabaka rally. I'm the person who gave the king the title of our, UNAIDS Goodwill Ambassador. And one of the things that is really made, which is very innovative, has been to make yearly Kabaka rallies. This is a rally of over 60,000 men and women, mostly men, running, and the messages there are really HIV prevention. And I think, working, just to emphasize that working with cultural leaders, to me, has been very great. The King Kabaka and also the King Oyo of Toro, they've been really super in mobilizing men. Thank you so much.
Thank you so much. Let's take one more. We'll have an opportunity at the next round to take comments as well.
Hello, colleagues. Thank you for organizing this session. It's so important. My name is Julie Pullerwitz. I'm from the Population Council and I2I. And what I wanted to share is that we had an opportunity to conduct a systematic review of reviews of male engagement programs, so with men and boys. And what we were able to see after looking at about 900 different studies, we used the lens where men were clients. So looking at things like VMMC, we looked at the lens of men as partners, where there are men and women involved. And we looked at how to promote in community engagement, or in that case, looking at more gender transformational, what might be called gender transformational programming, and men as agents of change. So we had three key questions. Will men come to programming, men and boys? Will the programming be successful? And will these programs apply to me in my country? And what we concluded were yes, yes, and likely yes. So the conclusions that we saw with these programs across low and middle income countries is that men were coming to the program, certainly with the different strategies we've been using. It was successful to reduce key outcomes like gender-based violence, promoting HIV testing. And when we think about where most of the results right now are from Eastern and Southern Africa, but also you see them in many settings across low and middle income countries. And we see that what we call gender transformational programming, or addressing gender norms and cultural norms, was the most successful strategy, as well as multi-level programming. So with individuals and partners and communities. Just wanted to share that contribution. So thank you very much.
Thank you. Thank you so much. Yeah. Okay, so I'm going to pass it on to my panelists. So you had a question, certainly. I think I would like you to speak to the Kabaka rally. It seemed like a very profound work. So perhaps.
Thank you. I'll start with the question raised about our tradition and our culture when we encourage people to test before you marry. Yes, testing is one of the key interventions that we encourage everyone to do, if they're going to marry or not. But at the point of marriage, it means that it is good for you to know the condition of the partners. So what you do after that is yours. Okay, we're not having yes, no, and all that, but it's important for everyone going into that to know their status and to keep it at that. So then in many of our interventions, I would like to applaud you bring it out. It was more better in other slides, but here we use activities, calendar activities, to run intervention. For example, our king is born in April. So a week before, we have what we call a Kabaka birthday run. The Kabaka birthday run is themed men to be the star. The theme we are running now is that men, protect yourself against AIDS to save the girl child. That is the theme this year. And the time she visited, we were at about 60,000 people. But on 7th April, we made 120,000 people engage in the run. So the whole country that morning, they endure the cold in the morning and come and we run for HIV. So we run, we have races in 21 kilometers, 10 kilometers, 5 kilometers, and people come out with placards and all that, and we rally the streets. Our routes are technically designed to go through the markets. We run the roads through the markets, through suburbs. That's where the run is tailored when we are making the routes of the run. So this is one lead that our king comes up and says, today, let's go for HIV by 2030. And we are now at 120,000, and next year we expect it to go beyond 150,000 people engage in the run. But that said, in terms of running, but we also have football matches. And in the kingdom, in a year, we run about 588 football games. And on the games where people come, where men come, there are placards, there is a message, halftime messages about HIV and all that. So this is how we've gone through. We have also gone to cycling, where we go 150 kilometers, riding bicycles with messages in a race and all that. So this is how the king is coming to rally people and men in terms of awareness. So we reach them in their areas, we take the messages and also guide change in that aspect. Thank you.
Fantastic. Carlos, wanted to say something?
Yeah, no, thank you. I wanted to actually respond to the STI question because I think that's a really important one. And it is part of both condoms and STI screening and treatment are part of the package of services for circumcision. There are millions of men who've been diagnosed and treated as part of the circumcision program. We unfortunately never collected that data. And I know that when we were trying to do the updated guidance, we wanted to bring in that data, and it never existed because it was never part of the indicators that we were measuring, unfortunately. But I do believe that at least from the screening and treatment aspect of it in the circumcision program we have, it's also important to note that, of course, circumcision also has an impact on STIs. And I think that it is, we don't do it for STI prevention, but it does have that benefit, not just to men, but also to women. Same with condoms, that it is part of the package of services. I did actually want to say something about the question about Botswana, because that was actually a really interesting question, followed up by what the minister mentioned about the process that it takes to engage a community. And I think from where I sit, speed, and we talk about speed, we talk about acceleration and all these words that I completely believe in, right? And the urgency of it is important, but the speed at which that happens, and when we're trying to change culture, that is not something that happens overnight, right? The CDC boss, the director of CDC, she says, change happens at the speed of trust. And like, it really, we set out a target of 90% for everybody at the same time. And like that, and we're trying to change culture at the same time. And like that is so, it was probably just very short-sighted in the way that we approached, certainly the way we thought of VMC, and probably the way we're approaching a lot of these other interventions, that, to really do that work of engaging a community in a meaningful way to change norms or change, that really is not something that we can just do overnight.
Absolutely. Building trust and making change in communities, takes time. And I think from the questions on STIs, but also what you mentioned here, Carlos, about missed opportunities as well, missed opportunities in collecting data, but also missed opportunities in how we reach men and how we engagement, because of certain assumptions as well that we make on where men need to be reached, where they are. There was work that was done recently in Malawi, which showed that normally we say men don't want to come to health facilities, for instance, but there was a study that showed that of men who turned up at an outpatient facility, only an abysmal percentage of them were actually offered HIV testing, which speaks to those missed opportunities as well, based on the assumptions that we make. I have actually Kate Dovell, who did some of that work in Malawi, and if you can come up and join us here. Round of applause, please, for Kate. So Kate is a very good friend. We've actually been working virtually over the last 2-3 years without meeting, but we finally met at this conference. So there's been questions even in the chat box about missed opportunities. What are those missed opportunities? I think if you can take us through, especially that work that you did in Malawi, the different missed opportunities that we can use to reach men.
Thanks, Wole, and thanks for putting this on, and fantastic panel thus far. It's really quite engaging. Yeah, so a lot of our work in Malawi has been within the health system, and really stemming from a place of wanting to understand, we have these assumptions about men, that they don't come to facilities, that we need to be in the community to find them. But what is the actual reality? How frequently do they come to facility? Why do they come? And how are we interacting with them when they are present? And so I believe it was 2021, my Malawi colleagues here, we did a community representative survey throughout about 48 communities in Malawi to ask these questions. And it was really interesting. We found men, over 80% of men came to a facility in the last 12 months. Almost all came to outpatient department, as you would expect. And on top of that, we had over 50% coming to the health facility as caregivers. So either accompanying a child, a friend actually happened quite frequently, coming with another man to support him, coming with a wife, other family member. So we have these men that are coming, certainly not as frequently as women, and we'll talk about that, but they are coming to the facility. What happens when they're there? And again, this is outpatient departments, so busy settings. We have, of those who are in need of HIV testing, we have less than 10% who are actually offered, and that was an option. Those who were offered, majority tested. Those who were offered were also probably those who were sick, who had some type of signals of advanced HIV. And so we saw this really amazing gap in men being at our facilities, not being offered any holistic counseling, HIV services, and other forms of just general care and health literacy. And so thinking about how, while absolutely reaching out into the community, finding men where they are, but when they are coming to our facilities, how do we start changing the norm? We say, oh, men don't like to come. Yeah, that is true, because the system also isn't set up for them. So when they come to the health system, how can we make it a more welcoming place? And it doesn't just have to be male-specific clinics. It can be that when they come to general outpatient department, that we have messages, health talks that relate to some of the concerns that they care about, that talk and offer additional HIV, STI services in private and respectful ways.
Just to add, we also in our culture, men don't cry. So when you're a baby and you're growing up and you're male, you fall down suddenly. What your granny or your father tells you, be strong. Men don't cry. What we are doing right now is that we're telling men it is okay to cry. Okay? And we're bringing this kind of brotherhood. So a man, look out for your other man. Where is he lost? What could be the problem? Because we've realized that some men have gone down in depression and gets lost from the community and does that. So we are saying that in Buganda, we are saying every man is brotherhood. It is okay to cry. Sometimes you cry, sometimes it is okay. So we have put that out of the men. And we have also not done it in terms of peer-to-peer in communities. We have also engaged other traditional leaders. We've talked to, we have had so many within Uganda who have come to the kingdom from Ankole, from Toro, from Bugisu. They have come to Buganda and we've engaged them. So as opinion leaders, if they all say the same thing, AIDS away from Buganda and AIDS still in Munich, we still have AIDS. So we are saying that AIDS everywhere is a problem. So we've talked to the Kabaka has met his colleague in the Mswati in Ghana. We have got close relationship with the Swatini. Okay, we've done that. We have also engaged the Duke of Edinburgh. Okay, we have had all those collaborations at both the cultural level, the national level, and our king is saying that every kingdom elsewhere in Africa or outside Africa, we still with HIV, we still have to work together. So the brotherhood aspect, pick a man, help a man, we fight HIV. That is how we do it.
What a powerful message. And I think absolutely, I was expecting that actually. I think that's a really powerful message as well on gender norms, right? So in communities and institutions, we have these assumed norms that force people to behave in a certain way. And I'm so grateful that a powerful figure like you is actually saying this right at the conference to change such perceptions. And we're going to come to gender norms in a minute, but I want Kate to speak to the WHO and UNAIDS framework on reaching men. So over time, we haven't had, guidance on what it means to reach men and how we can reach men. So you did almost an impossible job to develop this framework, and thanks so much for that. If you can take us through that framework succinctly on what are the key messages, because we heard condoms, missing from the conversation, STIs. What was that framework about?
Thanks, Wole. It was a absolute pleasure to work with many of you in this room and others on the framework. It was, incredibly difficult to pull together, but a really worthwhile task. The focus of the framework really was not HIV as a siloed focus, but HIV and other infections, other concerns that fit holistically and address a man as a person. So HIV, STIs, TB infection, and some others as well. And we did a scoping review of existing evidence and worked together with some just really fantastic, brilliant people on how do we pull this into a concise framework. And so really what we tried to do is come up with overarching strategies, priorities that can be applied across the various service delivery strategies or service entry points. And the main things, we used a person-centered framework because that really is what emerged from the evidence. And I think what you're hearing across the board here today is men want to be seen as humans, engaged, as a whole person, right? And engaged as a community. And so really a person-centered framing was central here. And there were 3 pillars. One is easy access, which overarchingly included entry points. So one of the things within a health system, we see that we have a lot of entry points into health system for women, particularly women of reproductive age, right? And we have some data that shows women with children under 5 are expected to come to the facility around 20 times or so per year for whether it be family planning, under 5 services. Men, it's really just HIV testing. You come once, right? Now, if you're an older man, there also is some screening for NCDs and things. But so increasing entry points for men, and when they are coming to the facility, really optimizing that experience. Another is obviously flexible, convenient services, and that's where a lot of community, incorporating community activities with community-based services can certainly help. So that's pillar 1, easy access. 2 is quality. So with kindness, respect, and being able to provide holistic, integrated services where possible. 3rd is then supportive. So then providing additional counseling and logistical support to those who need it. And I think some of the peer support, some of finding ways to encourage additional social support, whether that be through disclosure, through addressing gender norms, is quite key. So I think just very quickly, one, I think key thing that has stuck out as we're developing this and synthesizing the evidence is that it really, all of these things are what's good for everyone, right? Everyone wants easy access, quality, and supportive services. And I think what was key here is for us to find what are specific considerations of how to do that for men. And so to allow it to be just slightly tailored in ways that make sure that we're bringing men into the picture.
Fantastic. Thank you, Kate. I have to say as well that in that framework, in one of the annexes, you would find a package of services as well for men, including condoms, but others as well across the cascade. I'll be pivoting into a topic that I think it has come up a bit in the conversations from Sikulele to Carlos, Robert, Nelson as well, and Kate also mentioned. And it has to do with the messaging. It seems to me that there is a message problem with this men work that sometimes pits men against women. Make no mistake. A focus on women, preventing new infections in women is an absolute, right? However, the message is that without working on this huge men gap, we will be doing a disservice, not just to men, but also to women, but also to the, in fact, to the global AIDS response. I have the Deputy Executive Director at UNAIDS, Anjali Atreka, who, yeah, we all know Anjali. She's worked, you know, a lot in this space. Compelling speaker. If there's anyone who can help us to, you know, sort of bring that messaging together, this is what I'll be speaking to Anjali about. And thank you so much. What a pleasure to have you. So I'll be asking you the difficult question, which is, you know, that question about bringing it all together. You know, the joint program, I think is a unique entity in the UN that as well brings the different, you know, organizations, UN entities together. And I just wonder if how you see that messaging. How can we bring communities together, but at the same time, make sure that our messaging doesn't pit one group versus the other? What are your thoughts about this?
Yeah, no, thank you so much, Wole. It's great to be with you. This is a really important question that you ask, and I think it picks up a bit on what Kate was just saying around person-centered care. And actually, as I've listened to all of you, it's been such a privilege, really, to sit in this session and listen to you as you've been focusing on men and boys, while I'm not an expert at all on men and boys. And I've been in various other sessions learning from others, you know, on women and girls and on comprehensive prevention and what that looks like. And I think I'll come back to, I think, just some of the broader reflections, and then I'll come to the messaging in a minute. You know, I think as we look at any prevention programming, frankly, any kind of programming, I think it's really, really important that we start with data and we really understand when we look at the data in a disaggregated way, in a very granular way, across populations and across geographies, we can really understand where the gaps are. Sometimes it's with certain ages and with populations, like 15 to 34-year-old men for circumcision, or sometimes it's, you know, like you were showing in the slides here with the treatment cascades and the differentials between men and women on viral load suppression. You know, or sometimes it's in the community or the village of Buganda versus another, you know, community. So I think we always have to start there. What are the data telling us, and where are the precise gaps? And then I think it gets to, then how do we really tailor the interventions or the programming around what those specific gaps are? Just as you all have been saying, and, you know, Robert and Nelson, Kate, you all have been talking about this, Carlos, you know, that we have to then figure out, okay, based on where the gaps are, maybe it is circumcision interventions, maybe it is testing before marriage, maybe it is, you know, how we better optimize the opportunities when men are interfacing with the health clinics or the health facility. How do we tailor the programming in a person-centered way and use every moment we have to be as comprehensive and holistic as possible? So as it comes to messaging, you know, I think we all have to not pit ourselves against one another. We pit ourselves against women and men. We pit ourselves against AIDS, do we focus on HIV and AIDS or non-communicable diseases? It's always or, you know, are we, we're pitting ourselves against each other. So I think what we need to do is really work as we do across the joint program, different sectors coming together. How do we leverage one another and the opportunities that we have across different, even within communities, you'll have different ways, like you were just suggesting, Honorable Minister, you know, you're using moments when you interface with people, whether it's right before they get married, whether it's in the school setting, you know. So I think we just have to, it comes back to person-centered care. How are we looking holistically at the person? And then how are we bringing together whatever ways we can creatively optimize services for the person we're serving. In this case, we're talking about men and boys. So, you know, how then do we use fast track lines within health clinics? Or how do we, you know, integrate condoms and other things while circumcisions are happening? But it comes back to community and what community and people-centered care is really about.
Right. Thanks for those insights. Couldn't agree more. I think as well, you know, with the community engagement and engaging communities, perhaps one thing we need to look at as well, I think one of the panelists mentioned that, is men in their diversity as well, because it's a diverse population. Are there insights that you can share, Anjali, on what considerations we may have to address, you know, men in their diversity, including male key populations as well?
I mean, that's an excellent question. And that was something I was writing down as I was listening to you all. And it comes back to, again, we're hearing this and we know this in the programming. We have to be able to consider men in all their diversity. We need to be considering men who have sex with men. We need to be considering transgender men. We need to be considering those men who inject drugs, those men who are sex workers, those men who are cisgender men. I mean, and then tailor programming based on what those specific needs are. And we learn, the other thing I think is important, you know, I think there are a lot of lessons for us to learn across countries and across communities. You know, there's so many examples for, and this is just at the top of my head, you know, so many examples like in Thailand, for instance, on how KP-friendly services, particularly for men who have sex with men, are happening at the community level. Are we sharing enough across countries? Because I think as we truly look at men in all their diversity, you know, I think there are lessons we can exchange.
Thanks, Anjali. And, you know, I like that you mentioned the need to also have leaders, you know, but, you know, leaders not just in communities, in countries, it's, you know, ministries of health as well, national AIDS control programs. How are they, you know, bellying the cat and, you know, making sure that they're leading from the front and helping to join, you know, these efforts to improve outcomes for men. I will invite Mr. Ontiretse Lelare, who is the national coordinator of the National AIDS and Health Promotion Agency in Botswana, who can, you know, just help with insights, you know, certainly on ministries and the program. Thank you so much for joining. Anywhere on the panel. Thank you so much, sir. It's such a privilege to have you join. You've heard Anjali, you know, speaking on diverse elements, not just you know, for men in their diversity, but making sure that we get leadership and coordination right as well. And it's probably my first a question to you, if you can give us your insights on how difficult as well it is, with coordinating multiple, disease areas, not just HIV, but others as well, like we've mentioned across the cascade. What is that role of leadership and coordination in advancing this work on men and HIV?
Thank you very much, Wole, and good morning, colleagues. I want to make a few reflections as a way of responding to the question. But I want to start off by indicating that in Botswana, we have the legislature in Botswana is made up of two houses. The lower house consists traditional leaders. And the chairperson of the lower house of parliament, House of Chiefs, sits in the topmost decision-making body of the HIV response, and now non-communicable response as well. And this structure is chaired by the vice president of the country. So that's the importance of coordination. Coordination has to be done or driven at the right level. But I want to say, Honorable Minister, you did indicate that the King has interacted with quite a number of traditional leaders from across. May you be reminded that he also, the Prime Minister, interacted with the chairman of the lower house in Zimbabwe. So basically, that is that. We pride ourselves as a country in the fact that we have taken the position that particularly HIV is not a health problem, but rather cuts across. And that is why we have the leadership of the council driving the response being chaired from the office of the president. Initially, it was the president, now it is the vice president. And you have the council consists of a multi-sectoral stakeholders, so to speak, from government, private sector, civil society, the faith sector, and the traditional healers, if I could put it that way. And by so doing, the intention is to make sure that we reach out to all sectors of the economy with this aspect. As I've been listening to the panel, I want to make a few other reflections. In Botswana, what we see happening, particularly when it comes to new HIV infections, they are centered around adolescent girls and young women. A quarter of new infections are found there. And what we ask ourselves as the coordinating entity is, where is the infection coming from? Because when you look at their peers, the adolescent boys and young men, you would find that they are HIV-free. So chances are they're getting infection from somewhere, older men. And we are then saying to ourselves that there is no person who would intentionally transmit HIV virus to the next person. Possibly these are people who are unaware of their HIV positive status. So that's our focus area. And the leadership through the collaboration of civil society targets that. But I want to also indicate that I had a discussion yesterday with one colleague who is here about, well, indirectly, we're talking about the narrative of this poor health-seeking behavior among men. And the colleague works for a civil society organization.
which does testing and treatment. And the colleague says to us that 45% or 47% of people who come in for services at their centers are men. And when you look at the structure, the population structure of our country, you'd find that we are not far off the mark. 45%, 47%, 48% of the population is men. In some centers, you'd find that up to 53% of those that come in for services are men. So I wish for us to now kind of maybe get away from this narrative that men are not friendly with health services, because it is not proven. What we need to be doing, or what we need to be asking ourselves, is why are men then not presenting themselves to our public health facilities? That's where we should be looking into. That's where we should be working into around, just so that we get everyone to partake or participate in the health system equally. So generally, the leadership is very, very important when it comes to issues of response, and there is just no how you can do it without that.
Absolutely, some really profound words and thoughts there. Thank you so much, Onteretse. I think with what you have said is it speaks as well, not just to leadership and coordination, but also partnerships as well. So it's also about bringing everyone together, particularly in countries, but even globally. So we have PEPFAR, of course, who've done a lot of work. I mean, it's when we look back, my view is that at some point when this is over, hopefully not too long, we're going to be reflecting on the immense role that PEPFAR and other partners have made in helping us to kick this out of our consciousness, and to make sure that it's where we need it to be. We have Emily Kanye-Dokubo from PEPFAR. She's the Deputy Global AIDS Coordinator. I've actually met her once, actually. So I'm so delighted that you're here. Thank you so much for coming. Thank you so much, Emily. I'm sure you've listened to all of the speakers. You have a vantage position on on the ideas from the different panelists, and we've spoken from data to VMMC to Mr. Robert on the traditional structures, but also down to guidance and communities and leadership and structure and coordination. The role of partnership is so essential, and if you could speak to us about how critical that is, and how the men and boys agenda feature on the PEPFAR strategy.
Indeed, thank you very much, Wole. And as you mentioned, one of the benefits of going later is that everyone has said much of all the good stuff. So I can just say I concur with everything that's been said. But really, thank you very much to UNAIDS, WHO, GPC for really convening this, because this is an important topic that we need to discuss. As we know, we cannot achieve our goal of ending AIDS as a public health threat if we do not work to address the gaps that we continue to see. Again, we've made a lot of progress by working collaboratively across different programs, multilaterals, supporting partner governments, working with the community, but there's still a lot of work that needs to be done. And when we look at where there's still gaps, we see among key and priority populations, and even though men are not necessarily categorized as a priority population in terms of equity, there's still significant gaps, as you noted in the initial slides that you presented. And much of the success we've achieved has been through partnerships. And I think that is going to be essential for us as we continue to work to address these gaps. Historically, PEPFAR has prioritized areas where we see significant gaps, and we had initiatives like MenStar, which many of you may remember, worked public-private partnerships, working with multilaterals, and really, again, ensuring that we're working to close gaps in prevention and across the care and treatment cascade. Also, MENA for Men for Health, these were initiatives to increase awareness and ensure that we had better outcomes for men. And this is going to be essential for us to continue. And one of the points that I've noticed across the conference, the recurring theme, we have the tools already that we need to get the work done. But how can we better utilize them and take them to scale? And that is going to be important for us to do. Our partnerships, not just at a global level, but I also want to emphasize the role of communities. We talked about that earlier, and there have been some great examples. Well, we need to ensure that we continue to put community at the center of our responses. The role of faith leaders, traditional leaders, cannot be underscored enough. And I'll use some examples. I've worked overseas for past 8 years before coming back to headquarters. And in some of the countries where I worked, you could really see the benefit of when communities came together in partnership, working with the multilaterals to really get the work done at that field level on the ground. In Cameroon, for example, we had strategies that were really tailored to the different geographic areas because it's not a one size fit all. And in many places where you have differences by age, there's also cultural differences and religious differences that need to be taken into account. So one of the strategies we implemented was Sheferi testing. Sheferi are equivalent of chiefdoms. And so bringing in those traditional leaders where they created space and invited men to come in to get tested, to know their status, and also bring their spouses. And integrating services, including blood pressure screening, diabetes screening, prostate exams, STI screening. So these were some of the essential things that really helped to drive some of the improved outcomes and uptake of services that we saw. So partnerships are key for us at a global level, but also community and continued engagements, utilizing the tools we already know work. These are essential. And with PEPFAR, we have a men's initiative that has just been pulled together, seeing how we can bring all these best practices together and continue to prioritize and focus on men to close these gaps.
Fantastic. Thank you so much. There was a lot in what you've just said, Emily. And I just, would think that I concur, definitely on the fact that it really is not about, what we're doing or how we're doing it. My sense is similar to yours, that we know a lot of these things. The tools are there. Kate spoke to the strategy and the framework. It's more a question of, how come, right? If we know what to do and we know how to do it, then the question is, how come we continue to see, this continuing new infections, age-related deaths and so on. So I think we need to, and that's a reflection, on what you've said. It's a how come question. We have to, come together and respond to that question on how come, despite all of these, we still have, these numbers. So thank you so much, Emily. I think we have partners who are doing incredible work as well, on the field. Many of them are looking for opportunities, opportunities on, to collaborate, to partner, but also opportunities on funding as well. So if anyone in the panel, but probably I'll start with you, what sort of opportunities do we have for those in the audience?
Yeah, so I think the HIV response is multifaceted, and the unique resources and capacities that we have really all come together. And then that highlights the importance of coordination and collaboration and those partnerships. And it ensures that we're better efficient in how we're doing work. that we're working to close those gaps and focus in certain areas where those needs are, but also avoiding duplication of efforts. The unique strengths that we bring, how can we leverage those to, again, work to address where we see significant gaps so that we can continue to accelerate? And for PEPFAR, our focus as we're looking to 2025 and to 2030 is how can we ensure we're sustaining the gains that we've made while also accelerating to close those gaps, looking to 2030 and beyond, and ensuring that there's sustainability of the programs, HIV programs, as we've put them in place. And that is going to require political will, the programmatic aspect, which again, we talked about, we have many of those tools and resources at hand, and how can we ensure we're intensifying efforts and taking them to scale? And thirdly, the financial piece. Now, the reality is that we're working at a time where we see resources declining. And I think that really makes it even more critical for us to ensure that we are being very strategic in how we engage, and we're pulling our resources together to focus on what really matters and is going to make an impact. And so that is how we're approaching this, ensuring that we have programs that are simplified for partner governments to be able to take them on and carry them forward, and that us as donors and other multilats and partners working together can help to support that so that we do not lose the gains that we've made, and that the resources, even though they're becoming, we see that decline in the funding trajectory as there are other competing priorities, that we're able to focus those resources and put them where they're needed.
Fantastic. So just to say that I'm going to come to the audience just one more time before we close, and we are gradually, steering that conversation towards there. We have here with us Maya. I think it's, well, everyone knows Maya. So Maya is my go-to person at the Gates Foundation. And we're so delighted that Maya, who has been a huge supporter, I cannot say enough how Maya has supported all of the work that we've continued to do on VMMC and men, and they're doing so much in that landscape. It is my pleasure to have Maya join as well. And I guess I'll have just a couple of questions for you, Maya. The first is to ask you what you make of all of the conversation. You've heard loads from different people. What do you make of it? What do you make of this work?
Let's start with the easy ones, Wole. Good. And then just to say, I'm standing in for Dr. Yogan Pillay, who's the director of HIV at the Gates Foundation, HIV delivery at the Gates Foundation. So just to note that I lead a lot of our work in prevention and testing, and as Wole mentioned, have been working really closely with all of these colleagues actually in the men's space and otherwise. What do I think? I mean, first of all, I'm just really privileged to be sitting here next to all of these brilliant speakers. And I mean, really, really thoughtful, thought-provoking comments. I think, just to start by reflecting, I think what Carlos said, because I think that we forget that we have done a lot for men. And I'll start again with, I guess, with the VMMC program, which has reached more men than any program that I know of in HIV or otherwise, frankly, in global health response. And he said at that time that, there was a vision that had specific goals. We engaged partners, and partners meaning at all of the levels that I think my colleague from PEPFAR just mentioned, right? From multilaterals down to community levels. There were targets that were set by WHO, and Kate touched on that. And we had really thoughtful kind of approaches that were outlined by colleagues here. I think that so I think we've touched on all of the important points. I want to also reemphasize that, we have tools that we know work, and that's not just biomedical interventions. There are other interventions that we know that work and that where we've been able to reach people, and men are a critically important population. But I think Kate mentioned as well that what we need for men, we need for people. And so we need to be, really careful about what we're talking about here in terms of what has created these gaps and how can we think carefully about filling them. And I think my colleagues here have done a great job of highlighting all of those things. So
thank you so much, Maya. And just quickly, if you can as well speak to the Gates Foundation's a strategy. You have a strategy that as well focuses on populations. So for those listening, how do men fit in, and what opportunities are there for people to latch onto?
Thanks. No, that's a good question. So the Gates Foundation does have a strategy, which is currently being revised. So this is actually a great opportunity for me to come and listen to all of the brilliance on this panel and the questions from the audience to help inform those strategic directions. Men absolutely are a priority within that strategy. And we've been thinking really carefully about how do we close the gaps that you highlighted at the beginning? And so in thinking through that, at this stage, and as I said, it's being formulated, so I welcome, kind of feedback and thoughts on how we can improve it further. But we are starting with thinking carefully about the data. I think as Anjali mentioned, that's really a starting point for us to think about, also as was mentioned, we are at this stage of the response where we're looking at achieving epidemic control and scale. We want to make sure that we're reaching zero new infections and thinking really carefully about what sustainability looks like. And in that context, how do we do that? And men obviously are a clear priority in that. Where are they is sort of a question as well, and at what points, not only in the treatment cascade, but also for primary prevention, including condom programming and VMMC, among other options, what is relevant to whom and where? And so I think we're trying to think really carefully about bringing many different data sources together in the context of focused programming efforts that engage multiple stakeholders at multiple levels. So I can get into more detail on that, but that's sort of how we're thinking through it, taking a very person-centered and differential approach across different country contexts.
Brilliant, and we're looking forward to engaging more on how that strategy and that work evolves. So as we round up, I will take a few touch points with the audience. So if you would like to speak, just let me know. I know we have someone online. It's Fiona. So I would like to, just for the sake of balance, just have Fiona from Zoom. So I'll take the comment from Fiona, and then I'll go to Afsa first and the gentleman there. So is Fiona there? Okay.
I am. I apologize. I did not mean to raise my hand. Apologies for that.
I hope, yeah. So you didn't mean to raise your hand. I hope you've followed the conversation. I'm sure it's been worthwhile for you. But thank you for joining, Fiona. As I go to Afsa.
Thank you, Wole. I come from the ILO, and I would basically pick up from the last point you said, where are the men who are not being reached? And in our experience of doing workplace programs, we find these are basically informal economy workers who are mobile, who are migrants. They are not coming to health facilities to access services. So we need to take services to them. Now, in order to do that, we need to really map some workplaces that are highly male intensive, and we have done that. We have worked in mining, we have worked in construction. Just now the colleague was sitting here, he has gone for another session, wanted to share his experience of working on migrant workers from India. And we worked with them, and what we find that those who come through these efforts, a number of them are first-time testers, large number of them. We also find that most of them are asymptomatic. So they never feel the need to go to a health facility to get tested. And we also find that since they are working in the informal economy, for them going to a health facility is a lot of opportunity cost there. It means losing that particular day's wage to go to a health facility. So these are the things which we need to be aware of in order to enhance the engagement of men and take HIV testing to them. But we also find a lot of opportunities there in the workplace. A number of workplaces who have a health and wellness program. They want their employees to keep healthy and fit to work. So that's the opportunity that we have in mind. But my last point that I wanted to raise, and now that we have some people also into the policy making, what is our objective when we do programs with men with regard to HIV testing? When we do workplace programs, we don't find a lot of positives, but we do end up reaching a situation where a large number of men get to know their status. So that is the narrative which I want to draw your attention to, because now with close to 90% people know their status. The remaining 10% is very, very difficult to reach. So even if you get 2% people or less than 1% who know who are HIV positive, it's a good approach. But this is a small number, not be very attractive in the reports that you write. But at the same time, let's not forget the point that there are a large number of men who get to neither know their status. And that is the health-seeking behavior. So that is something which we are trying to crack and then find an answer to in terms of the indicators for success for this HIV testing program at the workplace. And we need to do that. But I would also see that there are lots of workplace resources which exist, which can be made use of in the program. Structures such as occupational safety and health, structures such as trade unions, structures such as private sector. So there's a lot of possibilities. Doesn't have to be a fully funded program in the workplace. But my main point is that what is the indicator for success when you do that program?
Yeah.
Fantastic. Yes, please.
I don't know if it is good morning or good afternoon. It's still morning. Okay. Yes. My name is Enole. I'm a native of Botswana. I reside in the USA. I'm glad Professor is here, the national coordinator and others. Perhaps what I would say would be so much directed to PEPFAR and UNAIDS as the big players in the HIV prevention, as we know. I like the point you raised, the moderator, about messaging. I come from a health communication background, and I think I would respectfully differ with the UNAIDS deputy director that it's not an issue of pitting one against another. Perhaps it's also acknowledging that while AIDS is indeed caused by a virus called HIV, we also need to accept the fact that we could be talking two epidemics in the global north and in the global south. The point I'm saying that goes to what the national coordinator from Botswana has just said, that new incidences are showing that adolescent females are getting more infected or at a rate higher than those of boys or adolescent males, which then translates to saying that older men are preying on younger females. And this is to say, therefore, that if that were to be true, AIDS in the sub-Saharan Africa context is largely transmitted among heterosexual couples. Largely. I'm not saying exclusively. And if that was to be the case, it then begs for us to address the issue of messaging very, very seriously. Because at the study I undertook 2 years ago, I was reviewing the effectiveness of PrEP using Truvada and U = U using Biktarvy. And these commercials are readily available on all the media channels that one can think of. And the young people in Botswana said they are not mirrored in those commercials. And here are drugs that are life-saving. Drugs that can, I mean, nobody can even dispute the science. They are the game changer. But if the young people in sub-Saharan Africa or in Botswana in this case do not see themselves represented in those commercials that have penetrated the globe, then I think we are missing the target in terms of who do we want our message to go to. So I think to close, it is the American health educator in 1956 by the name Dorothy Nyswander, who said, start where the people are. And with that point, I couldn't agree more with the minister from Uganda that a culture-centered health communication theory needs to be given a priority. Thank you.
Fantastic comment. Thank you. So we have probably a couple more comments in the room. So I'll take you first, and then my colleague from UNFPA, and a couple from down. So we're short for time. So please keep it very, it has to be very short.
All right, mine will be very brief. My name is Wole Ameyan from Botswana as well. I think mine was just, so we work primarily with adolescent boys and young men. And as we think about and re-strategize the future direction, recoursing, as Wole mentioned it, mine is just that we also infuse and integrate our mental health and well-being programming in all of our HIV programming, particularly for boys and young men, just looking at some of the norms that we've spoken about and societal pressures that we see boys and young men facing. Thank you.
Fantastic. So UNFPA, it will just be very short. I'm informed that we are short of time now, so please take that and then we close.
BDR, like you said, I'm UNFPA. I'm not even BDR, I'm UNFPA. Excellent conversation. I'm part of the working group on men and HIV. The first thing I would like to say, if we want to follow the direction of the deputy of UNAIDS, it might be my first thing that we might want to do is to really put men holistically, remove the word HIV so that we really focus on beyond HIV as we discuss all here, the brotherhood and all of those elements. But I just wanted to also say that this is quite interesting for me as the sexual health lead at UNFPA, because we've seen men involvement in SRHR, mostly with the lenses of men and HIV, right? And I'm thinking about sexual health for men. So going even beyond the diseases, we're talking about erectile dysfunction, we're talking about pleasure, we're talking about so many other things. And I think the next meeting of this group might be that something we need to do at UNFPA, because we need to know how to better do sexual health for men, including men, not only to involve them in our program as we're doing at the moment, in terms of men having responsible behavior to reduce sexual violence, but a little bit more holistically and beyond HIV, adding, as Gina was saying, not only condoms as we've been doing as well, but even beyond everything that we're doing to see how do we not replicate the way we did with women, but to try to do with men a little bit much broader than we've done with women and girls.
That's a fantastic comment. So holistic interventions and integrated as well. Unfortunately, we are out of time. So we're going to round up now with a summary. So I'm going to invite Anjali to make sense and put this all together.
Thank you. I'll try. And I'll respond to your question, sir, in your comment in my reflections as well. First, sorry. Okay, thank you. First, I just want to say it's really fantastic that we've had this conversation today. So thank you to the entire team that has put this together. I also think it's a really nice reflection looking at the people that have commented here from all sectors, from all sectors, donors, community, government, researchers, academia, implementation, philanthropy. I think it's a really nice reflection of what is needed. As I reflect in terms of summary points, I think I would say 4 things. First, maybe 5. First, I think it's really important that we acknowledge the progress that's been made for men and boys. It's really extraordinary. Yes, there are gaps that we've talked about, but the progress has been really, really extraordinary. So the 4 points as in summary, just as the director of the NACA in Botswana mentioned, and rightly mentioned, political leadership is so important to make sure that we continue to focus our efforts and to continue to move forward. So that political leadership, both for men and boys, but also for the entire HIV/AIDS response is critical. Second, I mentioned precision, but we heard it in various parts of the presentation. Data are people, we're talking about people, but we need to really continue to be precise with where our gaps are, where our people are, what geographies, what communities. Are they transgender men? Are they men in one community or another? Where are our men? So precision. The third, person-centered care. We have to use every moment we have to be as holistic as possible and really tailor interventions and programming in a person-centered way. And then finally, as Kaine noted, and we see represented across this panel here, is partnership. We cannot move forward without partnership. Wole, you started by asking, so if we have all these things, then how come we're still leaving men behind? I think the answer to that is that we are not approaching men and boys, nor are we approaching the new infections that are rising or the treatment gaps that still remain with urgency and with the same level of political commitment that we did in the past. And so that is why I think we're in the situation that we're in. So I think it's a call for all of us to continue that ambition, to continue with urgency. And to the question about messaging, I think we're saying the same thing. It's about how we really understand where the gaps are. Are there gaps in Asia? Are there gaps in Africa, in communities? And then how do we work with men? How do we work with communities to really tailor programming in a way that is men-centric, person-centric? So anyway, thank you for a fantastic discussion.
Thank you so much. A round of applause. Now we're out of time, unfortunately. I mean, I think we've had fun here. I've thoroughly enjoyed, speaking and hearing your thoughts, insights. And I'd like to just say thank you so much. You haven't made it difficult at all. I thought it was going to be really, really challenging bringing it all together, but I think we've had a coherent and cohesive discussion. So yeah, a round of applause to all of them. To those online as well, thank you so much for joining. I think we had up to 200, probably more online. It's an evolving conversation. We keep talking. Closed here. Thanks.